Please welcome to the IIS Educational Fund meeting at the SADI Congress, Science and Community in the Response to HIV and Co-infection in Latin America. The aim of this meeting is to reduce the gap between the latest scientific advance on HIV and their implementation. This session will focus on HIV and STD and the large burden of prevalent infection, including among key population. It will also present new paradigm after U and PrEP, the use of art for treatment and prevention of HIV, and a discussion of how to contain the STI epidemic. I am Monica Thurman from the Dominican Republic, member of EIS Governing Council for Latin America and Caribbean, and it is a pleasure for me to be your facilitator in this section on HIV and STD. We are going to have two interesting topics, HIV and STD in Stranger Bedfellows by Professor Kenneth Myers, and STI in the era of PrEP with Professor Jean-Michel Molina. So please, let me introduce you our first speaker, Professor Kenneth Myers. Dr. Myers is a medical research director and co-chair for the Fenway Institute. He is also professor of medicine at Harvard Medical School, professor of the Department of Global Health and Population at Harvard School of Public Health, and director of HIV presentation research and attending physician at Beth Israel Legit Health. Dr. Meyer is going to talk about HIV and STD Strange Bedfellows. Please, Dr. Myers.
Hola. Hello, everyone. I'm Kenneth Mayer from Boston, from Fenway Health and Harvard Medical School, and I want to talk about HIV and STI, why they're strange bedfellows. So we have to keep in mind that there are more than 1 million treatable STIs acquired every day. This just gives you the numbers of gonorrhea, chlamydia, syphilis, and trichomoniasis around the world. And the reason we care about the STIs is that there's a huge burden. There's over 500 million people with genital tract herpes infection, and HPV, which can cause cancer in women. 1 in 7 women have oncogenic HPV strains. Also, if we think about the burden of disease, we have to think about STI prevention as cancer prevention. It can severely affect pregnancy outcomes and infertility. And for our focus, it plays a role in increasing HIV risk of acquisition and transmission. And certainly the symptoms and the challenges to intimacy are affecting quality of life. So we talk about epidemiologic synergy. This term was first coined almost 30 years ago, talking about AIDS and it affecting poor populations. Judy Wasserheit wrote a paper showing how HIV and STIs interact with each other. And you can see on the right that data from New York and San Francisco suggested that the risk of acquiring HIV after having an STI is extremely high. So what is the synergy? Well, there's biology, because the STIs can cause inflammation or ulceration that increases HIV susceptibility or infectiousness. There are the behaviors that, the same things that lead to acquiring HIV are the same behaviors associated with STIs and vice versa. And then there's the epidemiology. People who have STIs tend to be concentrated in pools of individuals who may be at high risk for transmission, so-called core groups. And the HIV itself can cause immunosuppression that increases susceptibility and the expression of more severe STIs. But we're in a new era now. So PrEP and undetectable equals untransmissible means that if somebody is effectively on antiretroviral therapy, their risk of transmission is 0 if they're virally suppressed, if they're infected. And if they're on PrEP and they're adherent to PrEP, their risk of acquisition is exceedingly low as well. So we have unlinked synergy now where people can engage in condomless sex and be at high risk for STIs, but not necessarily HIV. And this has a global impact. Just very quickly, you can see here data from Thailand, people with HIV and at risk for HIV, high STI burden. This is not unique to one part of the world. These are data from South Africa and Nigeria among men who have sex with men, extremely high prevalence of gonorrhea, chlamydia, and syphilis, and another snapshot, young African women, very high prevalence of STI. So the populations that we are concerned about at this Congress, people at risk for HIV and people with HIV, are people where STIs are something that we have to think about as a way of life. There are multiple reasons for this. There's the biology that I mentioned. There's another factor for men who have sex with men and transgender women called role versatility. In other words, because anal sex is the most efficient way of HIV transmission, somebody can be the bottom, can acquire HIV very efficiently, but then if they engage in assertive behavior, they can be an efficient transmitter. So there's something unique about the biology that increases the risk for men who have sex with men and transgender women. But there are other factors that are common across groups. People at risk for HIV and STIs oftentimes may feel societal stigma. This may lead to depression, may lead to substance use, may lead to behaviors that avoid health seeking. People may be part of networks where even if they are not having multiple partners, their partners may be at high risk of having infection, so their risk for acquiring infection is high. There's certain venues, certainly we now know that there are apps that can be associated with HIV and STI transmission, and certainly before the COVID era, there are things like bathhouses that facilitated transmission, and certainly there are many social and structural factors that potentiate HIV and STI risk. So how can we decrease STI and HIV risk? And you'll hear somewhat more from Dr. Molina about some of the biomedical interventions, but I just want to touch on a few issues that we can think of as clinicians. Certainly we can screen people more frequently, and PrEP is an opportunity to do that. We can do a better job of providing partner services. There are tailored ways that we can do a better job. So there are clinics like the Dean Street Clinic in London, and these are two screenshots on the side where you can see this is something where people can come in, they can input their data on a touch screen computer, and they can then get text messages when their test results are back. We can also do a better job of integrating STI services. We need to do more cross-training for providers, certainly, and we have to address the social and structural impediments, and then there are improved diagnostics that are coming down the pike. So in terms of integration of services, one of the more innovative places in the world has been New York City. They talk about an HIV status neutral approach. So somebody comes into the clinic, if their serostatus is unknown or they've had an HIV test but have been sexually active recently, the first thing is to test. If they test negative, then assess them for PrEP and get them to engage in PrEP. The same day PrEP starts. If they test positive, similarly to get people to know their status and to get them on treatment. So the reframing is sexual health clinics as opposed to disease-focused clinics. Instead of STI or STD clinics, it's a sexual health clinic is the new mantra. The other issue is the workforce. A colleague of mine, Doug Krakauer, calls it the purview paradox, which is that infectious disease specialists have said primary providers should prescribe because these are not people living with HIV. And primary care providers say, PrEP is for specialists. We really have to cross-train so that everybody sees themselves as a practitioner around sexual health, because this is a very common set of issues for humans, and however people present to the system, we have to be prepared to offer a comprehensive package of services. Part of this relates to cultural competence training, and that is that many times people who are at risk for STI are socially marginalized, and sometimes we as providers are the biggest problem, but there are ways to provide more welcoming care, to ask somebody what are the gender of your sex partners, for example, as opposed to saying, do you have, are you married, do you have sex with somebody of the opposite sex, and making a heterosexual presumption. There are a variety of training tools, and I've listed a website. Our center has funding from the US federal government, so LGBTQIAhealtheducation.org, or if you just go to the website of Fenway Health, you have a lot of materials that can be downloaded that can provide cultural competence training. Another revolution is the whole idea of bringing the services to people at their homes. So there are a variety of private for-profit companies now in the US where people can order STI testing, get a test kit at home, fill it out, send it back, and get the information. These home services can also be means of getting contraception, means of getting PrEP as well. We're in the process now of studying routine HIV self-monitoring for PrEP care. So we have a study called PrEP at Home. We did a pilot which found that it was highly acceptable. And now we're studying this in 4 US cities, and we work with a group called Molecular Laboratories. We have a video that shows participants how they can self-swab for the STIs and how they can prick their finger. We can then screen for creatinine as well as for HIV and syphilis and give the people their results back. And we're evaluating whether this is as effective as coming into seeing a clinician. And in the COVID era, this may be a very useful adjunct for clinical services. And then one of the last points I'd like to make is that there are newer diagnostics. This is just one I'd like to call your attention to, but this has been approved by the US FDA. It's a 30-minute genetic test. It can be done in a clinician's office. There are a variety of other point-of-care tests. So if we can turn around the test more quickly, we can tailor treatment for the STIs more effectively. So in conclusion, the advent of U equals U and PrEP have unlinked HIV and STI transmission when users are adherent to either of the antiretroviral regimens. But STI rates remain extremely high among people with HIV and PrEP users. HIV and PrEP care can be a major opportunity to test for and to treat STIs, and that could limit their spread. And we need new models of HIV, PrEP, and STI care where we provide one-stop shopping for people who are sexually active. We really need to retrain the workforce, use newer diagnostic technologies, including internet-based technologies. And if we scale up these approaches, we may be able to do a better job in STI control, as well as in maintaining people on PrEP and ART. So I want to thank my colleagues who've contributed slides, and here's the website for our clinic if anything I mentioned referring to our clinic might be of interest. And thank you for your attention.
Thank you, Professor Meyer. We will continue with the next presentation before we begin the question and answer section. So our next speaker to be is Professor Jean-Michel Molina. Dr. Molina is a professor of infectious disease at the University of Paris, Diderot, in France, and head of the infectious disease department at the St. Louis Hospital in Paris. Dr. Molina is going to talk about STIs and the era of PrEP. Please, Professor Molina.
Hola, my name is Jean-Michel Molina from the University of Paris, and it's a pleasure to be part of this educational fund from IES in South America. I have been asked to address the issue of STIs in the era of PrEP, and this is indeed a very controversial issue. These are my disclosures. And let's start directly with this meta-analysis of STI diagnosis among people starting PrEP, and in that case, these individuals were MSM, men who have sex with men. And this analysis looked at a number of open-label study and randomized trials, looking at the rate of STI before starting PrEP and during PrEP. And the bottom line here is that overall, in people on PrEP, there is an increase in the rate of STIs by, as you can see here, 24%. And this increase is actually significant for rectal STIs, for rectal chlamydia, and it seems to be greater in recent studies as compared to older studies. But at the same time, we have to acknowledge that among MSM in Europe, and in particular in England, but this is true all over the world, we have seen over the last 15 years, and even more in the last 5 years, an increase in the rate of a number of bacterial STIs, syphilis in red, gonorrhea in green, and chlamydia in purple. And these increases actually predated the implementation of PrEP in the UK by many years, since PrEP was introduced in the UK in 2015, and you can see that this increase in STI rates was actually quite obvious as early as 2010. So this increase in STI that we see among MSM is probably due to a reduced use of condoms among MSM. At the time, we have better treatment for HIV, and we know that the treatment associated with undetectable viral load is a guarantee that there is no risk of transmission to the different partners. And therefore, the use of condoms has decreased over the last couple of years. So there is no surprise that there is an increase in STIs. But to really know whether it is PrEP that is the cause of STI increase, it's important to look at the study where PrEP was given to MSM. This is data from the PROUD study, where MSM in England were randomized to receive immediate PrEP in blue or deferred PrEP after 1 year in orange. And what you can see on this slide is after a year of follow-up, a pretty high rate of STI in both groups, and the rates were not significantly different whether you look at all or STIs or only gonorrhea, chlamydia, or syphilis. And in addition, because the testing rate was actually higher in people with immediate PrEP, that would balance the results. And if you look at the overall incidence of STI with immediate PrEP, you can see it's 62 per 100 person years, and it's 55.8 in the deferred arm. And the confidence interval actually overlap. So this study gives you an example that it's not PrEP by itself, which is the cause of STI increase. It's because people using PrEP are at high risk of HIV and other STIs. And because they are tested more frequently, you will diagnose a lot of STIs in these individuals. Let's look at a more recent study from Australia, the PrEP-X study, where actually the authors were able to look at STI incidence in these individuals within a year before starting the cohort study and within a year during the cohort. What you could see here on the first row is that the incidence before entering the PrEP study was 69 per 100 person years, and it increased to 98 during the PrEP study, which gives you an adjusted incidence rate ratio adjusted for testing frequency of 1.12. So if you do a comparison before and after, you have a 12% increase in the rate of STIs. But if you look now at those individuals who were already PrEP experienced when they started the cohort study, you see that the adjusted incidence rate ratio was actually 1.05 and not significantly higher than 1. So in these PrEP experienced patients, overall and over time with PrEP, there was no increase in STI rates. The increase was seen, however, in the PrEP naive population, those who started PrEP at the time they entered the PrEP-X study in Australia. And you can see that these STI incidence increased from 55 to 94%, but you adjust for testing frequency, the increase is only 21%. And it's really difficult to know whether this is, I would say, the increase we see in the general population among MSM in Australia, or whether it is an increase due to the use of PrEP. And we don't know the answer for sure. What we know, however, when you look at the distribution of participants and STI diagnosis, is that some participants here, nearly 50%, will not present with STI during their participation to this PrEP study. And actually, it's only a low proportion, 25% of the participants in this PrEP study, who accounted for 76% of all STIs. So when we think about how to contain STIs in people using PrEP, we have to focus on these 25% of participants who are responsible for the majority of STI diagnosed in people on PrEP. So how could we contain STI in PrEP users? So we have to use some of the lessons we learn with HIV and start with A, B, and C, abstain, be faithful, and condoms, which are, behavioral intervention that may actually contain the rate of STIs. In the PrEP-X study, again in Australia, there was an interesting multivariate analysis to look at the predicting factors of STI in this population of PrEP users. And as you can see on this slide, 3 factors were identified as associated with a risk of STI. Younger age, a number of anal sex partners. So if you increase the number of anal sex partners, you increase your rate of STIs. Group sex also was associated with an increased rate of STIs. But as you can see here, even though there was a trend toward an increase in STI without the use of condoms, this increase was not significant. And these data actually tell us that, of course, we have to recommend the use of condoms in people using PrEP, but actually that may not be the main driver of STIs in PrEP users. And actually, we should try to let them understand that they have probably to reduce also the number of the sexual partners. What about data from another PrEP study that we are conducting in France in the Paris region, where you can see in red over time the increasing rate of STIs in this population. After 18 months, we had an incidence rate that was close to 100 per 100 person years. And we were able to look at the rate of STI during the COVID-19 lockdown. It was interesting to see that during the lockdown, there was a significant drop in STI incidence from 100% to less than 20%. And of course, that is evidence that abstinence could induce a reduction in STI incidence, but of course, this is not a viable long-term option for these people. So what else could we do? Vaccine is clearly very attractive, and this is similar to the COVID-19 epidemic, where we are looking forward to seeing a vaccine being available. That's the same for vaccines for STI. We have very good vaccines for viral STIs, but we don't have any vaccines for bacterial STIs right now, and we are developing more research in order to have these or to make these vaccines available in the future. For viral STIs, although we have good vaccines, we still have to use them better. And if we look at these data from Taiwan, you can see that at the end of 2015, they were able to identify 2 HIV-infected individuals who had acute hepatitis A infection. And a couple of months later, they were able to document an outbreak of acute hepatitis A infection in Taiwan with nearly 1,500 cases, most of them among MSM, and most of them among MSM who had HIV co-infection. So they implemented a public health strategy with the implementation of the hepatitis A vaccine for all HIV-infected individuals and all individuals who attended STD clinics. And within a couple of months, they saw a strong decline in the number of new acute hepatitis A infection. And when they conducted a multivariate analysis to identify predicting factors of acute hepatitis A in these individuals, they identify a recent history of syphilis as being associated with acute hepatitis A. And also, they were able to identify the high effectiveness of hepatitis A vaccines, since individuals who receive a single dose or 2 doses of vaccine were highly protected with an effectiveness that was above 96%. So clearly, in people on PrEP, you have to document and to make sure that these people have protection against hepatitis A, against hepatitis B, because we have very effective vaccines. What about antibiotic prophylaxis? This is a very controversial issue for STI today. We presented 2 years ago the results of a randomized study among MSM using PrEP in France, and where actually we randomized them to receive either doxycycline post-exposure prophylaxis. Within 24 hours after sex, people have to take 200 milligrams of doxycycline, or no post-exposure prophylaxis. In that study, people in the doxy arm used a median of 7 pills per month, so not a lot of pills, and each pills contain 100 milligram of doxycycline. What we saw after a median follow-up of 8.7 months in the panel A here was an overall reduction by 47% of the risk of bacterial STIs. If we looked at gonorrhea, there was no difference in incidence, so no benefit. The benefit, however, was quite strong for chlamydia and syphilis, where the relative reduction in incidence of chlamydia and syphilis was nearly 70%. So following these results, a couple of people in Australia, in the UK, started to use doxycycline for STI prophylaxis. We don't think this is a good idea. And although it's a limited number of people who are using doxycycline prophylaxis, I think at this point, it is not recommended to use this prophylaxis because we are not sure the efficacy is high enough and is consistent if we repeat the study. So we have a single study at this point with a limited number of people. And on the top of that, we need to really assess the impact of this prophylaxis on resistance. And we don't want to induce resistance of chlamydia and syphilis to doxycycline with this strategy. So we need to do more studies, and there are a number of ongoing trials in Canada, France, in the US as well, and in South Africa to really assess within the setting of a randomized study whether there is any harm of using this prophylaxis. We also need to assess its impact on the microbiome overall, because antibiotic prophylaxis could have, as we know, an impact on other bacteria, of course. An interesting strategy that is being tested in Australia right now is the use of an oral mouthwash to prevent oropharyngeal gonorrhea. Indeed, in a pilot study among MSM, these investigators were able to show that the use of an alcohol-containing mouthwash for 5 minutes, you gargle with the mouthwash for 5 minutes, and this treatment was able to reduce the rate of positive culture in people who had oropharyngeal gonorrhea from 84% to 52%. So there seems to be some activity here, and that's why our Australian colleagues started a randomized controlled trial to see whether the daily use of this alcohol-containing mouthwash would be able to reduce the risk of acquiring oropharyngeal gonorrhea among MSM, and we know that oropharyngeal gonorrhea is quite frequent in this population. So what about the test and treat strategy? That's a strategy which has proven to be quite successful to contain the HIV epidemic. What about STIs? We have models from the CDC which let us think that if we test more frequently STIs, the yellow line is testing STI every year. Here with the purple line is every month. If we test more frequently these individuals for STI, and if we treat all people diagnosed with STI here in yellow, we may be able, over the course of the next 10 years, to reduce by 40% the rate of gonorrhea and chlamydia in PrEP users. And of course, with STIs now in people on PrEP, because we test them more frequently, we diagnose a lot of asymptomatic STIs, which would have been missed if we were not testing these individuals. And we may think that, you know, more frequent testing, more frequent treatment, earlier treatment may prevent transmission to their partners. Do we have any real life data? Well, in France, we were quite surprised to see in 2016, and that was confirmed in 2017, that, you know, the increasing rate of syphilis actually was replaced by a plateau in the number of syphilis cases among MSM in orange here. And although MSM represented 81% of all cases and 36% had co-infection with HIV and gonorrhea, this plateau here, which was seen just at the time of PrEP rollout in France with more testing for STI, more treatment for STI, might be, you know, the first example of the success of such a strategy. And of course, we need to, be careful, cautious, and wait for additional data in 2018, 2019 to make sure that this is indeed true. Let's finish by partner notification and treatment. This is also an important strategy to try to contain STIs in PrEP users. And I would like to remind you of a study that was done in South America, in Peru. So you might be very familiar with that study conducted among MSM to see whether expedited treatment of sex partners would increase partner notification. And in that study, 173 MSM with STI were randomized to receive either standard counseling for their partners or counseling plus a prescription of 2 antibiotics, cefixime and azithromycin. And the primary outcome of the study was to see whether there was an increase in self-report notification of the partners. And indeed, in people who received ATP, there was an increase in the proportion of partners notified, 83% as compared to 58% with standard partner referral. So that was encouraging. However, we were disappointed to see that the rate of recurrent chlamydia gonorrhea in these individuals was actually not reduced by ATP. So there is more work to be done in this area and more studies to carry out. So in summary, we know that following PrEP implementation, there has been high rates of condomless sex and high rates of STI diagnosed, also because we are testing more frequently these individuals. But what's important to underline is that these high rates of STI and condomless sex did not undermine the high efficacy of PrEP to protect individuals against HIV acquisition. We need to test for STI more frequently in order to make an early diagnosis and rapid treatment with better partner notification. This should help to reduce STI incidence in PrEP users. Of course, we need to do more research and test new behavioral and biomedical strategies, and we probably need to push for vaccine development and vaccine for bacterial STIs in particular. Obviously, community and individual empowerment is key to address this issue of STIs in PrEP. And we know there are no magic bullets here, and we need sustained efforts and combined approaches in order to address this issue of STI epidemic, in particular among PrEP users. And overall, there is a need to renew focus on STI research now. We have documented this increase in STIs among MSM, not only among PrEP users. And so we need to do more research now to meet the 2030 WHO UNAIDS goal to reduce the incidence of STIs and HIV by 90%. I'd like now to thank you for your attention and for listening to this presentation. And I will conclude by acknowledging my team in Paris, where you're welcome to visit us and to work with us if you're interested in PrEP and STIs. And I would like also to thank our funders and sponsors over the years with our PrEP and STI studies. Thank you. Bye-bye.
Well, thank you, Professor Molina, for your speaking. It was very interesting. And now we are going to start the question and answer section. I have 4 questions, so feel free to answer the one you feel more comfortable. The first one is, what information, most important action is currently needed to effectively scale up testing of STIs? In your opinion, what is the role of the government within national health programs in the term of raising awareness on PrEP and STI? What are the biggest challenges and barriers to scaling up testing of STIs in the region? And what needs to be done to facilitate access to testing of STIs and PrEP for key and vulnerable populations? Please, doctors.
Thank you, Camilla. Thank you very much for your kind comments. It's a very important issue, actually. And I think you need to have clear guidelines in your government to recommend testing for STIs. So that it would be easier for a clinician and for patients to understand, that they need to be tested. And what we have learned with PrEP is that, people are coming to see their doctor to get the prescription, but what they are most concerned about is whether or not they have an STIs, and they are very happy to know that they have no STIs and they have no risk of transmitting STIs to their partner. The other limiting issue with STIs we are facing right now is the cost of testing. And what we need to do is to be able to provide testing for STIs at low cost for individuals. There are multiple options to do that. but that's a key element of acceptability and implementation of testing for STIs. The last issue I'd like to mention is also the issue of rapid testing. In order for people to be, to accept to be tested and to understand the role of STIs, it's important that the results could be available quite soon after testing, so that people could receive treatment in due time and be treated before they can transmit these STIs to their partners. So I think, guidelines, cost, and rapid turnover time to obtain the results, these are key issues in an STI strategy in people using PrEP.
Thank you, Professor Molina. Any comment, Professor Meyer?
Yes, I agree with Professor Molina. I would only add that, number one, each country, each city really needs to look at where STI testing can be done. Syphilis testing is very easy. There obviously is there are quality assurance issues, but the technology is 19th century technology still when we're using antibody tests for confirmatory testing. So we need improvements in how we diagnose syphilis, but for the time being, the tests that we have available are fairly simple. But for gonorrhea and chlamydia in particular, we really should be using NAT testing, and that involves expensive machines. But in many countries, there are machines that are used to test for TB or used to test for other pathogens that use the same technology, the nucleic acid amplification. And there really needs to be a more holistic look rationally about, can the central lab that does the TB testing also test for gonorrhea and chlamydia? Because we know that using culture for gonorrhea and trying to test for chlamydia, unless you're doing nucleic acid amplification testing, you're really not doing the best testing that has the greatest sensitivity and specificity. And many of these STIs are asymptomatic, so you're going to miss a lot if you just say, well, I treat syndromically, or I only screen syndromically. We also need to make sure that providers are culturally aware and competent so they get a full sexual history, because just because somebody's urine test or urethral test is negative does not mean that their rectal tests or their oropharyngeal tests will be negative. So we have to be able to get enough of a history to know where to screen as well. So that's also part of the puzzle. And a lot of this, again, relates to really training the provider workforce so that people are more comfortable talking about sex, talking about STIs, and then knowing how to best screen, diagnose, and treat.
Well, thank you, Professor Meyer. Well, thank you to our speakers for presenting and participating in this session, especially during this special and very busy time of the year. We would like also thanks for all the participants, and we hope that this session has been helpful and interesting for you. We also encourage you to share the recording of this session with your colleagues who were not able to participate with us today. They will be able soon at the EIS Education Fund webpage. We hope that the information shared during this meeting will help you to detect actions to reduce the gaps between scientists, advance and implementation, and personal and professional levels, but also in your action at the local and regional level in America. Thank you all. Take care of yourself and enjoy the next section on HIV cure and vaccine research. Thank you, professors.
Thank you, Monica. Bye-bye.
Gracias.
Hola, muy buenas tardes, muy buenas noches para algunos, quizás buenos días para algunos. Es un honor estar aquí en esta sesión. Les doy la bienvenida a la reunión de la IIS Educational Fund en colaboración con el Congreso de la Sociedad Argentina de Infectología 2020. Quiero dar la bienvenida a todos los participantes de esta reunión conjunta bajo el tema Ciencia y Comunidad en la respuesta al VIH y co-infecciones en América Latina. Soy la doctora Claudia Cortés, médico infectólogo de la Universidad de Chile, vicepresidenta de la Sociedad Chilena de Infectología y miembro del Governing Council de la International AIDS Society. Esta cuarta sesión la vamos a centrar en las investigaciones sobre la cura del VIH y las vacunas, incluidas las últimas actualizaciones sobre estas dos esferas de gran importancia para la respuesta al VIH. Tenemos dos excelentes ponentes, incluyendo la doctora Sharon Lewin, presidenta electa de la IIS y directora del Peter Doherty Institute of Infection and Immunity de Melbourne, Australia. También nos acompaña el doctor Jorge Sánchez, subdirector del Centro de Investigaciones Tecnológicas, Biomédicas y Medioambientales de Perú. Ambos tienen un muy extenso currículum y la verdad es que yo me voy a centrar en escuchar sus presentaciones y más adelante les puedo ir contando un poco más de ellos. Los dejo con la doctora Sharon Lewin.
Thanks very much. It's a great pleasure for me to be able to present to you today. I'm going to discuss advances in the science towards a cure for HIV and potential pathways to the clinic. So I think everyone knows that HIV cure is rare, but certainly possible. The first person to be cured of HIV was, of course, Timothy Brown, who unfortunately died just 2 months ago from recurrence of his leukemia. He was cured following transplantation from a CCR5 or resistant donor and remained off antiretroviral therapy with no detectable virus for over 10 years. And so it was an inspiration for many of us working in the field that a cure is possible. For many years, we didn't know if this could be repeated. And then 10 years later, Adam Castileo from London was reported to also have been cured of HIV following a bone marrow transplant from a CCR5 negative donor. So this really did confirm that we can do this. The question is how to make it available and safe to the 37 million people living with HIV. Earlier this year, we heard about Lorraine Willenberg from San Francisco. Lorraine's never been on antiretroviral therapy, hasn't received a transplant, but has successfully controlled her virus for over 20 years. And we've traditionally thought of this as elite control. However, what was discovered with Lorraine was that any virus that was there, and there were fragments of virus there, was defective. And we now think that this might be another pathway to a cure. Finally, we know that some people can undergo post-treatment control or remission, meaning they can keep their virus under control after a short period on antiretroviral therapy. This was first described in France, but then larger studies performed in the US, showing that in people who initiate treatment in the first 6 months of infection, what we call acute infection, can stop, when they stop treatment, about 10% can keep the virus under control. So the overall goal is, can we mimic what has happened in these individuals in the 37 million people living with HIV, allowing them to safely stop treatment? Now, I'm going to briefly give you an update on new concepts in our understanding of HIV latency. I'll then talk about clinical strategies for an HIV cure with a focus on immunotherapy, broadly neutralizing antibodies, and gene therapy. And finally, talk about some of the thinking in how we might one day implement an HIV cure. So there are two forms of HIV-infected cells. One is productive infection, where the virus enters an activated CD4 T cell and replicates. That cell will be positive for DNA, positive for RNA, positive for proteins, and generally will die. We also know about latent infection. In this form of virus, the virus gets into the DNA of a cell and therefore is detected as DNA positive, but doesn't produce RNA, doesn't produce proteins, and therefore survives. What we've learned, though, is that it's not as simple as two forms of infection. there's actually a spectrum of activity between productive and latent infection. And this occurs even in people on antiretroviral therapy. So some of the new concepts in HIV persistence and latency that we've learned over the last 12 to 24 months include, first of all, reservoir activity. The virus is not always silent or fast asleep. It can intermittently activate, or it can dribble out very low levels of virus in people on treatment, what we now call the active reservoir. Latently infected cells can proliferate, and we know this because we can find cells with the identical integration site. This couldn't happen by chance. It's happened by proliferation, and that is a new target for HIV cure. We know that position matters. Where the virus integrates is actually really important. And earlier this year, we learned that in a subset of elite controllers, people who can naturally control their virus, the virus is in a special part of the DNA which allows it to stay silent, perhaps indefinitely. And finally, we know that on treatment, most of the virus is actually defective, meaning it's got mistakes and errors in it and can't really replicate. It's like a graveyard of viral sequences. And this is the dominant form. And in fact, there's very few cells that have intact virus. And we've got much better ways of measuring defective and intact virus and getting far better insights into what happens with intact virus rather than total virus on antiretroviral therapy and following interventions. And the news is good there. It looks like intact virus does decay to some extent. So what are some of the clinical strategies for an HIV cure? Well, the overall goal is to eliminate these latently infected cells. If you were able to eliminate every latently infected cell, essentially what happened with Timothy Brown, we call this eradication. Alternatively, if we could just reduce the amount of infected cells and enhance the immune system to facilitate long-term control, this would allow people to safely stop antiretroviral therapy, but the virus is always there at low levels, and we commonly call this remission. Currently, the strategies are aimed at both. We ultimately would like to achieve eradication, but most of the work so far is really targeted at achieving remission. So the strategies to achieve an HIV cure are targeting the virus, reducing the amount that's left on treatment, and bolstering the immune system. And there's multiple ways to do this to reduce the amount of virus that persists on antiretroviral therapy, and I've named some of those interventions here, and at the same time boost immunity. And I'm going to just talk about a few of these strategies, namely latency reversal, immunomodulation, and a very little bit about broadly neutralizing antibodies, and finally summarize what's happening in the world of gene therapy. So latency reversing agents, we have traditionally called shock and kill, drugs that push the virus out of its hiding place so that the immune system can now see the infected cell and eliminate it, effectively converting a latently infected cell to a productively infected cell. And there are many latency reversing agents that have been developed in the lab, some that have been tested in clinical trials, and probably the most active agents currently under investigation are these drugs called SMAC mimetics, but they have not yet been in people, only encouraging data from animal models. What we've learned from clinical trials, though, is that there still is a need for more potent and less toxic latency reversing agents that we can move into the clinic. We've learnt that we can shock the virus, but we can't yet kill those cells. And there's an amount of work now going into effectively getting the kill into shock and kill through pro-apoptotic drugs or drugs that enhance cell death. There are, though, immunomodulatory latency reversing agents, and these have the dual activity of targeting the virus and the immune system. And the drugs I'm going to talk about are immune checkpoint blockers and TLR agonists. And these are attractive because they target both the virus and the immune system. Visotolimod is a TLR7 agonist that's been extensively studied in animal models. It has immunomodulating activities and is now being used in multiple combination cure studies. It probably has some activity as a latency reversing agent that's been shown in vitro and in some non-human primates, but its real role is in immunomodulation, and that's shown on the right, the activity it has on different markers of the immune system. In one non-human primate study, the combination of TLR7 agonists with antibodies actually led to cure in 50% of animals, which has given people a lot of optimism that this agent's going to be important. And just a few weeks ago, we heard the results of the first clinical trial of Visotolimod, a TLR7 agonist developed by Gilead, in people living with HIV on antiretroviral therapy. The study was a dose-escalating, double-blind, placebo-controlled trial in 48 individuals, and it was shown to be safe with minor adverse effects, and it had clear immune-enhancing effects at doses greater than 4 milligrams, and this just shows you some of the immuno-enhancing effects. Interestingly, it had no latency reversal, at least on its own, and there are now going to be, and many studies underway, combining Visotolimod with other immune-enhancing agents. One of the agents that will be combined with are broadly neutralizing antibodies. I'm sure many people know about these. These are derived from HIV-infected individuals. The source of those antibodies, or B cells, is cloned ex vivo, and there's a very large number of HIV neutralizing antibodies, some of them very potent, that are now in the clinic. They're being investigated to prevent HIV. They've been investigated in place of antivirals. And we also know that in people living with HIV who receive an antibody and then stop treatment, there's prolonged time to viral rebound. So they are thought to have a role in cure strategies. Finally, we've been interested for many years in anti-PD-1, a drug that can reverse the exhaustion of the immune system and potentially help control virus off treatment. We recently completed a study together with Afam Okoye and Lewis Picker, where monkeys were infected with virus, put on treatment, suppressed, just like someone on ART, and then given anti-PD-1 or a control antibody. And I'm going to show you the results according to this legend. Now, when we looked at the time to rebound in these monkeys, there was no difference. All the monkeys rebounded mostly within 10 days after stopping treatment. But when we looked at control after stopping antiretroviral therapy, and this is viral load that rebounds, you can see the control antibody in blue, it stays at a very high level. But in monkeys that received anti-PD-1, viral load is reduced by 2 logs. This is not good enough for a cure, but clearly shows that anti-PD-1 can enhance immune function. Now, what's happening in combining some of these strategies in the clinic? Well, there are a number of combination immunotherapy studies now underway. This is a summary of some of them that have been reported, including River and Roadmap, and some of them that are still enrolling. And they largely combine latency reversing agents with antibodies or vaccines. And then there are many other immunomodulatory agents that I haven't discussed, interferon alpha, IL-15 superagonist, and others. And the results, we should hear of some of these studies in the coming 1 to 2 years. Finally, gene therapy. Gene therapy is important because we now have much better ways to edit the DNA. This allows for multiple ways we could tackle the virus. First of all, gene therapy can use to attack or enhance anti-HIV immune responses. It can be used to protect, where you can engineer uninfected cells to be resistant to HIV, or it could be used to purge, which means directly eliminate the virus, target the gene editing tools to the virus itself. The real challenge for gene therapy is the delivery. At the moment, most gene therapy is delivered ex vivo, gene editing outside the body, which needs to be then reinfused. However, advances in vivo gene editing could really change the options for gene therapy for HIV. This is an example of ex vivo gene therapy for CCR5 modification. Cells are taken out, modified ex vivo. The CCR5 negative cells are then reinfused back into the person living with HIV on treatment. And we know this approach is safe. We just need to get it to be more effective or higher levels of gene modified cells. What's really exciting over the last few years is hearing about in vivo gene therapy, where you can deliver the gene editing tool with either nanoparticles or an adeno-associated virus. And studies delivering gene therapy to produce broadly neutralizing antibodies were recently reported at CROI this year. Finally, and importantly, how will we one day get any of this into the community or implement an HIV cure? Well, if you look at what we have available for HIV treatment now and in the future, here we are in 2020 with highly effective antiretroviral therapy that's oral. In the coming months, or maybe within 1 to 2 years, we'll have long-acting or injectable antiretroviral therapy, either as tablets or either as injections of ART or broadly neutralizing antibodies. So cure strategies would likely initially be targeting HIV remission with combination immunotherapy. Hopefully, we'll then move into seeing ex vivo cures or gene or cellular therapy moving into the clinic, followed by in vivo cure, and the ultimate goal to get a single shot cure for everyone. Now, I don't know when this is going to happen, but I think one could expect that we will have some forms of combination immunotherapy, which would at least allow for remission as one pathway to get to this final goal. Together with the Bill and Melinda Gates Foundation and the IAS, we've been developing a conversation around what a target product profile for an HIV cure might look like. And this combines what will be useful to the community with what will be possible from the science. The target product profile is commonly used in drug development. It aligns all stakeholders by defining a cure product that people living with HIV actually want delivered. It defines the minimally acceptable and optimistic characteristics of a cure in relation to a whole lot of parameters like efficacy, toxicity, cost, who it's for, how it's transported, etc. And we've already started a consultation with a number of experts and community where we did a range of interviews in person and verbally, and an online exercise trying to define the minimally acceptable and optimistic characteristics. And these data should be published shortly, in fact, hopefully on World AIDS Day. So just in summary, there are many new concepts in understanding HIV latency. There are new tools now being used to understand how the virus persists beyond just quantifying the virus as DNA or RNA. Combination immunotherapy approaches are most advanced, including using TLR agonists, antibodies and vaccines. Anti-PD-1 may also play a role, although there is some safety concerns with this intervention. There's some optimism for gene therapy, including strategies to attack, purge, and protect from the virus using both ex vivo and now in vivo approaches. And finally, there's active discussions right now with funders, industry, and community about what a target product profile for cure will look like. And the overall goal is to ensure that any advance we have scientifically will be delivered quickly to those at highest need and in a form that's acceptable to the community. I'd like to acknowledge all of my colleagues at the Doherty Institute in Melbourne who've contributed to much of the research that I've done over many, many years and done all of the hard work. Many of our collaborators and funders. Thanks very much.
I am Jorge Sanchez, Principal Investigator of the Gates-funded Clinical Trial Unit in Peru, Vice President of the Centro de Investigaciones Tecnológicas, Biomédicas y Medioambientales en Lima, Perú, Affiliate Professor of the Department of Global Health at the University of Washington, and HBTN co-chair of the Mosaico trial that I will talk about during this presentation. I have no conflict of interest. And in this first slide, I want to show the differences between regions of the populations affected by HIV. Although HIV has slowed down during the last years in the world, there is still 38 million people infected, and over 1.7 million people are infected every year. This slide shows in circles the population affected by a region. You can see, for instance, that in South Africa, the pink circle represents young women, while in the Southeast Asia, the purple circle represents people who inject drugs. And these are the main people affected by the infection in this region. As you see in the Americas, the populations that are more affected by the infection, HIV infection, are men who have sex with men and transgender women, who are represented in green and light green circles across the Americas. The prevention has been evolved during the last years, and this slide shows a mosaic of different prevention strategies. Each tile is a strategy. We can see undetectable means untransmissible, condom use, mutual monogamy, and PrEP. PrEP has evolved during the last 10 years a lot. In year 2012, was approved and to use TDF and FTC to use daily to prevent HIV. After that, it has been effective also during the same year in 2012, shown that 4 tablets per week has the same, more or less the same effectiveness of every day. And this was using the STRAND study in combination with the data of the HYPERG study. After that, the HYPERG study shows effectiveness also using PrEP on demand, 2 tablets 24 hours before sex and 1 tablet 24 hours after sex, and another tablet 24 hours after. Recently in 2019, TAF has shown non-inferiority results with TDF FTC. And this year, intramuscular cabotegravir has shown superiority to TDF FTC. It means that PrEP has been evolved a lot during the last decade and will continue to be evolving. However, the tile of the vaccine has not been filled and requires to be filled for people that the other strategies do not work or they do not desire to use. Why is it difficult to find a vaccine? There are many reasons. Immediate and irreversible HIV integration in the host genome is one of them. No immunogen have been designed and predicted yet able to elicit broadly neutralizing antibodies. Immune correlation of protection are unclear. Sorry for the typos. And natural infection and recovery do not occur, providing no mechanism of action for a vaccine to emulate. No validated preclinical models of disease transmission has been are not usable. But more importantly, there is an extensive HIV clade and sequence diversity. There are 9 subtypes and more than 50 recombinant forms shown in the figure to the right. And you can see the different subtypes and different recombinant forms by region. This slide shows you the different trials, 2B and 3, that has been undergone in the last 30 years. There has been a lot of research, and there is only one trial that has shown efficacy, and that trial is named the PI trial. Is the one who is in the middle here, and this trial it has shown efficacy. The PI trial used 4 priming injections of a recombinant caranipox vector plus 2 booster injections of a recombinant glycoprotein 120 subunit vaccine. After 3 years of follow-up, the efficacy was around 31%. With this information, HVTN modified the regimen to implement HVTN 702, shown here below, which has been implemented between 2016 and 2020. This HVTN 702 vaccine trial used a vaccine regimen consisted of 2 experimental vaccines, a caranipox vector-based vaccine called ALVAC HIV, and 2 component GP120 protein subunits vaccines with an adjuvant to enhance the body immune response to the vaccines. Both ALVAC HIV, supplied by Sanofi Pasteur, and the protein vaccine supplied by GSK, were modified from the versions used in the SADI trial to be specific to the HIV subtype C in South Africa. This study was performed in South Africa for young women. Additionally, the protein subunit vaccine in the HVTN 702 was combined with MF59, a different adjuvant that the one used in the TI trial, in the hope of generating a more robust and durable immune response. Finally, the HVTN 702 vaccine regimen included a boosted shots at the 1 year and 18-month time points in an effort to prolong the early protective effective shown in the trial. Unfortunately, this trial showed no effects. Besides these trials, in this slide also is shown trials done in MSM, like the IVAX trial, the STEP trial between 2004 and 2007, and the HVTN 505 trial. All of them were non-effective among MSM. These trials were basically done in the Americas. Research done from 2004 and on and supported by Johnson & Johnson has shown in the last few years promising results. In 2016, the study approach assessed the safety and tolerability of various regimens. Participants were primed at weeks 0 and 12 with adenovirus 26 mosaic HIV, expressing mosaic HIV envelope, M, GAT, and POL, and were boosted with adenovirus 26 mosaic HIV or modified vaccine Ankara, with or without low or high dose of aluminum adjuvant clay C envelope GP140. The HIV adenovirus 26 at 26 plus the high dose of GP140 boost vaccine was the most immunogenic in humans. The same regimens were used in rhesus monkeys that were actually have a very good immunogenic results, and these monkeys were rectally challenged at least 6 times with a decrease in the infectiousness of 67%. After this study, the second study here, the Traverse study, showed that the tetravalent mosaic HIV vaccine induced a superior magnitude of cellular and humoral responses, immunity than the trivalent vaccine. This vaccine concept is currently being evaluated for efficacy in young women in Southern Africa in the HPTN 705 study or in Bocodo trial, with a final enrollment of over 26,000 people. Aiming to expand the scope of global coverage, the ASEM study here included an HIV mosaic GP140. And the data here show broader immune responses. The adenovirus tetravalent HIV and the bivalent GP140 selected at final rating for a phase 3 trial, which is the one used in the Mosaico trial, which started in November 2019. Therefore, we have currently 2 trials using similar schemas. The Invocodo trial, which is a phase 2B in Southern Africa, predominantly in clade C, heterosexual women that have an intravaginal transmission and have a limited PrEP use. On the other hand, we have the Mosaico trial, which is a phase 3 trial, done in the Americas and Europe, where the predominant clade is the clade B. The target population are MSM and transgender women, which have an intrarectal transmission, and there is an increased PrEP use expected. The primary objective of the Mosaico trial is to evaluate the vaccine efficacy of a heterologous vaccine regimen utilizing adenovirus 296, mosaic tetravalent mosaic HIV, and aluminum phosphate adjuvate, clade C GP140, and mosaic GP140 for the prevention of HIV in HIV seronegative cisgender men and transgender individuals having sex with cisgender men and or transgender individuals. The primary endpoint is confirmed HIV infection diagnosed between 7 months and on, and will be followed for 24 to 30 months after the last injection. Secondary objectives are to evaluate the safety and reactogenicity, to evaluate the vaccine efficacy at other time points and in other analysis, sub-analysis populations, to evaluate the immune responses elicited by the vaccine regimen, and to evaluate the vaccine efficacy by and adjusting for potential confounders. Here is the schema of the Mosaico trial. We see here 2 groups, the intervention group and the placebo group. The intervention group will have 4 points of vaccination. The first 2 points at 0 and 3 months will receive adenovirus 26 mosaic tetravalent HIV vaccine, and this vaccine will be included a clade C plus a mosaic GP140 in the vaccination in month 6 and month 12, and will be followed, as mentioned, for 24 to 30 months for the primary analysis. This study has been powered at 90% to reject the null hypothesis of the vaccine efficacy less than 20% under an assumed vaccine efficacy of 65%. The sites where the Mosaico study is done is in the Americas and Europe. There are 22 sites in the US, 3 sites in Mexico, 5 sites in Peru, 8 sites in Brazil, 4 in Argentina. And in Europe, there are 2 sites in Poland, 3 in Italy, and 6 in Spain. This slide shows the current enrollment up to November this year. You can see there are 491 enrollment. The countries that have enrolled more are Peru and the US, and the other countries have just started and is progressing the enrollment. I want to show here the mechanism of PrEP Mosaico. We know that PrEP is effective, and there are different stages in our Latin American countries of the coverage of PrEP. So we wanted that everybody who wanted to be in Mosaico had the chance to choose PrEP. Participants in screening were counseled about PrEP and linked to PrEP services during the pre-screening processes, if they are interested. Linkage to PrEP services occur instead of trial participation. Science linked interest people to PrEP service. Potential participants who declined to use PrEP were screened and enrolled in the trial. After enrollment, if participants change their mind and decide to use PrEP at any time during the trial, they are linked to PrEP services or provides PrEP at the site. Also have approved PrEP access plans for both the screening and post-enrollment periods. And all participants need to get all of their HIV tests through the study site because of vaccine-induced seropositivity. What is vaccine-induced seropositivity or seroreactivity? The vaccine is creating antibody responses. That's the goal of an HIV vaccine. Most of common HIV tests detect HIV antibodies, not the virus itself. The vaccine recipients may produce antibodies against HIV proteins in the vaccine. Therefore, vaccine-induced seropositivity occurs when antibodies created by the vaccine causes reactive results on the standard HIV test. This can be misinterpreted as a sign of HIV infection in a healthy study participant. And therefore, every participant should test their HIV testing at the site. In summary, despite prevention efforts, MSM in Latin America remains a substantial risk of HIV acquisition. Although data among transgender women is scanned and in established HIV surveillance systems, studies indicate high prevalence in this group. Deployment of prevention strategies such as treatment as prevention and PrEP is slow, especially in Latin America. Therefore, there is a momentum for finding an HIV vaccine. Ethical considerations have been taken in the designing of Mosaico. A Mosaico study deployment is underway. All the sites participating in Mosaico has a PrEP plan in place. And this is common, and participants should take HIV tests only at their CRSs or clinical research sites. I want to thank the Janssen team, especially Sabrina Espinosa, who have shared their slides, and the HVTN team. Thanks so much.
Thank you very much. Now I will go in English so our guests can understand the question easily. Remember that everybody can send your questions in the Q&A box, so please send us all your doubts and questions. I want to thank Professor Sharon Lewin because for an excellent presentation, and also Dr. Jorge Sanchez, who talk about vaccine, and Dr. Lewin about cure. I have a couple of questions for both. Dr. Lewin, how do you, the shock and kill strategy with these latency revergency agents sounds very aggressive. What can you tell us about adverse effects that patients can maybe have?
Well, first of all, none of the trials looking at latency reversing agents have shown a reduction in the reservoir. So it's important to understand that this won't be used on its own. What studies have shown is that you can wake up the reservoir, which is the first step to eliminating it. So if we're going to use any latency reversing agents, they'll be used in combination with other strategies. The adverse events from the shock and kill strategies that have been used so far are largely related to the drugs themselves. So the interventions have included histone deacetylase inhibitors. They've got a range of adverse events. Anti-PD-1 has a range of adverse events. And I mentioned TLR7 agonists that were initially developed as a latency reversing agent. The idea of increasing activity of the reservoir, that to date has no evidence of causing any harm, because even if you produce more virus, it can't go on to infect cells in someone that's already on antiretroviral therapy.
Okay, thank you. Dr. Sanchez, what do you think are the main difficulties you see in a HIV vaccine trial? Recruiting patients, the active vaccine movements. Do you think that these movements for this specific vaccine is going to be the same for the other vaccines, and we have to deal with these movements? You need to open your mic.
I'm so sorry. As I mentioned, there are several potential drawbacks in the development of a vaccine trial, and recruitment and retention is one of them. I think for MSN in the Americas, it has been going through different trials that has not been effective already. So since late 1990s, there have been trials among MSN in the Americas, and that might have some reluctance in the community for this. And trial sites need to work with the communities, trying to introduce the idea of that the trial will not produce a major adverse event. The current regimen have a Mosaic 26 platform vector platform that has been used in almost 1,100 people in the world by other vaccines like Ebola, respiratory syncytial virus, and other viruses. So it's a safe platform. And so far, what we are looking or what in the already enrolled participants is that only produce local symptoms, signs, and minor systemic signs. Obviously, we need to have a long follow-up to see if there are other long-term adverse events showing up. But I think one of the good news in this trial is that it has been tested in macaque rhesus. We know that there is no real model for reproduce the immune system of the human immune system in the monkeys. However, this schema has been tested in monkeys rectally challenged. So they have been introducing the rectum different quantities of virus, and they had a 65% of reduction. you might remember that for PrEP, we start doing the same. We start doing challenging monkeys that that receive PrEP, and we find out that they were very successful in preventing HIV infection. So I think we have the hope that this new trial will work, and so the sites in many Latin American sites are working hard to work with the community.
Okay, thank you very much. Dr. Lewin, how do you see the HIV treatment in 10 more years? What can I offer to my patients if you think in 10 more years?
Well, I think in 10 years, we will have injectable antiretroviral therapy. I think that's a given. We may well also have injectable antibody treatments, and antibodies may have some advantages over antivirals with respect to adverse events, and it's potential that we can use antibodies that will last, say, 6-monthly injections. We might even have implants where antiretrovirals are just like we have a contraception, we may have implants. I think if I look in 10 years, there's a very high chance that each of those will be available to patients as alternatives to daily oral treatment. With respect to cure strategies or something that we can give people so that they completely stop antiretrovirals, I'm really not sure we'll even have that in 10 years, actually. If any of the things that we're trying work, the most likely thing that we will see first in the clinic are these what I call combination immunotherapy, an approach that will reduce the reservoir and boost the immune system and allow people to stop treatment. But I think that's very uncertain when it will come to the clinic.
Okay, this has been an amazing session, but we are getting to an end. Thank you to our speaker for presenting and participating in this session, especially during this special very busy time of the year. We will also like to thank all the participants, and we hope that this session can help and be interesting to you. We hope that the information shared during this session and this meeting will help you to take action to reduce gap between scientific advances and implementation at a personal and professional level, but also in your actions to the local and regional in Latin America. Thank you all. Take care. Please take care about COVID. There's still a lot of COVID out there. And I invite you to enjoy the next session, the next panel about stigma and discrimination. Thank you very much.
Thank you.
Thank you. Bye-bye.
Hola, buenas tardes con todas, con todos y con todes. Bienvenidos a la última sesión del día que tiene que ver con un tema muy íntimamente vinculado con lo que se ha estado discutiendo el día de hoy, que es el estigma y la discriminación. Esta es la quinta sesión que vamos a tener en español o portuñol en honor a la Sociedad Argentina de Infectología y a su 20 aniversario, una organización para todos nosotros muy importante, no solo a nivel académico, sino un socio recientemente en el mundo del activismo para mejorar la calidad de vida de las personas con enfermedades transmisibles y poniéndolas a ellas en el centro de la respuesta. La sesión tiene que ver con la ciencia y la comunidad en la respuesta al VIH y co-infecciones en América Latina. Este es un evento organizado con el Fondo de Educación de la Sociedad Internacional de SIDA y, por supuesto, la Sociedad Argentina de Infectología dentro de su Congreso. Quien les habla es Javier Orcade Veloc. Yo soy editor y coordinador de corresponsales claves, un equipo de periodistas comunitarios de la región. Digamos que esa es la peor parte de mi reputación, el resto se los ahorro. Y en realidad la sesión de hoy se centrará en discutir en un breve panel el tema de estigma y discriminación sobre el VIH, y para eso se ha seleccionado 4 panelistas de lujo. No me quiero comer el tiempo porque el panel va a ser muy breve, pero sí quiero presentar a la moderadora del panel, que es Claudia Velázquez, de ONUCIDA, actualmente ONUCIDA Brasil, una colega y compañera con muchos años de trayectoria, no, más allá de ONUCIDA, una persona que siempre nos ha aportado muchísimo conocimiento académico, pero también que viene de la respuesta al VIH y conoce que la ciencia no es solo la respuesta para esta pandemia, y por eso qué mejor para moderar el panel y presentar a los panelistas que Claudia hablando sobre estigma y discriminación.
Muchas gracias, Javier, y bienvenidos y buenos a todos al panel. Voy a introducir brevemente nuestros 4 panelistas. Tenemos a la señorita Karen Dunway de ICW Latina, Honduras. Ella es una activista desde pequeña. Actualmente está liderando una investigación Nosotros Sabemos, Nosotros Podemos. También tenemos a María José Hernández, que es integrante de ACEPO, Asociación de Ayuda al Seropositivo de Uruguay. Y también tenemos a Matías Muñoz, que es activista, abogado y fundador de Asociación Ciclo Positivo. Y la última panelista es Silvia Martínez, de Red Trans Nicaragua, actualmente coordinadora nacional de Red Trans desde el 2005 y también coordinadora de proyectos del Fondo Mundial. Entonces, con eso les quiero avisar a los panelistas que voy a hacer una ronda de preguntas introductorias. Les pido que traten de limitar sus respuestas a 3 minutos y luego, tiempo permitido, quisiera iniciar una segunda ronda de preguntas. Entonces, la primera pregunta es para Karen Dunway. ¿Qué pasos deberían ser realizados para colocar la lucha contra la estigma y discriminación como el eje principal de la prevención y tratamiento al VIH en su país? Karen.
Hola a todos y todas, gracias por la invitación. Yo creo, y siendo este un punto muy necesario a recalcar, y lo hemos notado mucho en el área de jóvenes de ICW Latina, al momento de ejecutar nuestra investigación, que nosotros sabemos, de que es necesario evidenciar cómo el estigma afecta la vida de las personas con VIH, ya que, como sabemos, es una limitante para los derechos humanos de las personas. Y se deben hacer cambios en las políticas públicas para que las acciones de discriminación sean consideradas como delitos. Disminuir el estigma, en parte, depende del diseño, la aplicación, programas, políticas, leyes e investigaciones en que múltiples sectores se comunican y colaboran para lograr mejores resultados de la salud pública, porque el estigma es una barrera para el acceso a estos servicios de salud y también para lograr ambientes de trabajo, entorno social, familiar, libres de estigma. Esto Esto de evidenciar no solo cae en el tema de investigación, que es diagnóstico y tener datos, porque en esta investigación que nosotros hemos estado haciendo hace ya un par de meses, nos hemos topado con la noticia de que casi no hay datos, específicamente de mujeres jóvenes VIH en Latinoamérica. Y eso nos da la limitación de saber en qué contexto estamos parados y cómo vamos a poder tener acciones específicas para disminuir el estigma y la discriminación. Pero también en Latinoamérica, y cierro con esto porque quiero ser muy breve, se debe darle seguimiento a las campañas de estigma para que tengan un impacto permanente. No solo que sea 1, 2, 3 meses, sino que sea largo para ver grandes efectos. Gracias.
Muchas gracias, Karen. La siguiente pregunta introductoria será para María José. María José, ¿qué debería ser implementado para reducir la estigma y discriminación en los centros de salud?
Bueno, buenas tardes para todas, todos, todes. Reflexionando en este sentido, lo que yo llegué hoy como para aportar es que una de las claves es poder darnos cuenta y poder trabajar sobre el currículum oculto que los centros de salud de alguna manera tienen, ¿no? ¿Y a qué me refiero con el currículum oculto? Al sistema de valores, creencias, pensamientos, matrices de aprendizaje, modelos de sexualidad que cada persona que trabaja en ese centro de salud trae consigo, más allá de la formación académica por la que puede haber pasado o por la formación administrativa. No sé en los países donde viven ustedes, pero acá en la carrera de medicina no existe el espacio para la educación sexual integral. Por lo tanto, no hay un lugar para la revisión de estos modelos de sexualidad, heteronormativos, genitocentrados, androcéntricos, ¿no? Un montón de creencias que hacen que no se puedan revisar. Entonces yo creo que lo primero que hay que implementar es ese trabajo de educación sexual integral permanente en los centros educativos, en los centros de salud, con todas las personas que allí trabajan, y para mí esto, la clave fundamental es la presencia de las organizaciones de la sociedad civil en los equipos de trabajo. No como algo accesorio, sino justamente como en una cuestión de equidad, de experticia y de saber para que esto se pueda ir transformando. Pienso que tiene que haber material educativo al alcance de las personas, pienso que tiene que haber videos educativos desde un punto de vista positivo, no alarmantes. Pienso que la consejería tiene que estar instalada acá en las guías y las pautas de tratamiento. Se sugiere y se exige que la consejería esté presente dentro del centro de salud, pero es algo que no se ha implementado y la sociedad civil por lo general es quien se encarga de eso. A veces nos olvidamos el vínculo que tiene esto con la sexualidad, y la sexualidad es un tabú. Las infecciones de transmisión sexual han sido concebidas durante mucho tiempo como castigo, y eso, por más que nosotros y nosotras somos activistas, lo venimos trabajando, lo tenemos en nuestro cuerpo, esas personas que trabajan dentro de los centros de salud tal vez no están teniendo el espacio, la posibilidad producida para que puedan revisarse y transformarse hacia un paradigma, más acercado a la realidad, y más justo, más equitativo, y yo creo que eso reduciría, pero ampliamente, ese currículum oculto que recibimos cada vez que tenemos atención médica o que algún compañero o compañera se acerca al centro de salud. No sé si me pasé, perdón.
Estuvo bien, María José, muchas gracias. La siguiente pregunta introductoria entonces será para Matías. Matías, ¿de qué manera puede el sistema de entrega de servicios de salud ayudar en la reducción del estigma y discriminación hacia personas que viven con el VIH?
Bien, yo creo que coincido muchísimo con lo que dice María José, ¿no? La información es una herramienta fundamental para poder... Creo que la discriminación, el estigma y la discriminación surgen a partir de la falta de información. Casi todas las personas discriminamos o excluimos de alguna manera a otras personas. Y eso tiene que ver muchas veces con la falta de empatía, la falta de información, la falta de conocimiento. Hay algo que tengo para decirles, ¿no? Que muchas veces estas situaciones se pueden reducir con esta información y con capacitación. No es nuevo decir que el estigma y la discriminación se puede reducir con capacitación. Pero me parece que hay un cuello de botella que todavía no pudimos sortear, y es en pensar a todo el equipo de salud, a todo el personal que trabaja en el sistema de salud como el equipo de salud, ¿no? No solamente entender a la capacitación de los profesionales o las profesionales de la salud, psicólogas, médicos y médicas, ¿no? Pensar también en administrativos, en personal de seguridad, ¿no? Un punto que muchas veces la puerta se cierra en esa puerta de entrada al llegar al equipo de salud. Pero creo que esto no es nuevo, no es algo que empezamos a decir en el 2020 o en el 2019 o ni siquiera en el 2018. Entender al equipo de salud como distintas personas que interactúan con nosotras, personas usuarias del sistema, es un desafío que todavía lo tenemos pendiente y que si bien lo venimos diciendo hace muchísimo tiempo, todavía no llevamos a la práctica la capacitación conjunta de todo el personal que trabaja en el equipo de salud. Entonces, lo que tengo para decir en esta primera instancia es eso, ¿no? Lo mismo que venimos diciendo hace mucho, pero llevarlo a la práctica. Realmente entender a todas las personas que trabajan en el equipo de salud o en un servicio de salud como objetivo de las capacitaciones. Pero hay que hacerlo, hay que empezar a hacerlo. Y en segundo lugar, es esta herramienta y esta estrategia fundamental que tenemos nueva desde hace algunos años, que si bien indetectable igual a intransmisible aplica solamente, ya lo sabemos, para personas con tratamiento más de 6 meses y por vía sexual, el mensaje tiene una fuerza imparable. Y que digamos, que mencionemos que una persona con VIH no puede transmitir el virus, hace que esos miedos, que esa desinformación se reduzca. Entonces, realmente tomar en serio el mensaje, poder prestarle atención a la fuerza que tiene y a las consecuencias positivas, a los resultados positivos que tiene este mensaje, es otra de las posibles soluciones. Por eso, en resumen, son dos. Es empezar a hacer lo que venimos diciendo que hay que hacer, que es pensar en el equipo de salud como una multiplicidad de personalidades, y en segundo lugar, darle a I igual a I el lugar que se merece.
Muchas gracias, Matías. Y vamos con nuestra última pregunta con la cuarta panelista. Silvia, ¿cuáles son los desafíos y barreras más grandes para poner fin al estigma y discriminación en su región o país?
Antes que nada, explicar un poco que la región de Centroamérica en este preciso momento ha cambiado. Y esto se lo debemos a los 2 huracanes que acaban de pasar. Se cuentan en cientos de miles de personas aisladas, en crisis humanitaria, crisis sanitaria. Esto agrava el tema del acceso universal a los servicios de salud. Creo que... Y también decir, ¿verdad?, de que los desafíos son muchos, porque al final el sistema patriarcal tiene salida. Pueden agregar, pueden decir que, ejemplo, como lo han dicho uno de los panelistas, el tema de las concepciones morales, que es un tema nuevo, como el tema, de ejemplo, de las personas transgénero, el acceso a los servicios en el tema de VIH. Sí ha habido avances, pero también hay retrocesos. Y muchas veces esos retrocesos, creo que como sociedad civil, nosotras y nosotros debemos empujar, y debemos empujar este carro en el sentido de que el acceso universal solo se puede garantizar cuando todos y todas podemos acceder a los servicios sin estigma ni discriminación. Ese es uno de los desafíos. Y creo que otro de los retos es con el tema de la financiación del Fondo Mundial. Generalmente los países solicitan inversión para los recursos humanos en capacitación. Es que también esta capacitación, más allá del tema de VIH, sea también con un abordaje contra el estigma y la discriminación para mejorar los servicios de salud.
Muchas gracias, Silvia. Si me permiten, creo que cada uno ha aportado unos ejemplos muy importantes sobre cómo están manejando la estigma y discriminación, cómo deberíamos de dirigirnos para responder a esta situación. Pero quería regresar con una segunda pregunta, si me permiten, a cada una rápidamente. Karen, si te puedo hacer una pregunta de seguimiento. Hablaste sobre barreras en los servicios de salud, falta de datos, y quería preguntarte también si sabemos la importancia de poner la comunidad al centro a la respuesta al VIH, pero también son parte clave de combatir el estigma y discriminación. ¿Cómo se han organizado las comunidades en Honduras para abordar este tema?
En Honduras, como lo dijo Silvia, también está afectado demasiado por el huracán ETA. Hubieron más de 1 millón de afectados y todo el contexto que tiene Honduras es totalmente diferente y no va a volver atrás. Eso lo cambió para siempre y aparte con el COVID, siendo un país de bajos recursos, sin tanta educación, mucha gente no se cuida del COVID y todo el contexto de Honduras ha cambiado. Ya no hacen tantos grupos focales como antes, algunas casas hogares cerraron y en este contexto de COVID, de huracán, no sabría muy bien cómo responderte esta pregunta porque todo está este año ha sido tan raro que todo ya no es igual. Entonces se hace como lo que se puede. Eso es, se hace lo que se puede y la virtualidad no es para todos. Y más en países como Centroamérica.
Gracias, Karen. Totalmente de acuerdo que realmente América Central realmente ha sido muy afectado no solamente por el COVID, pero ahorita con esta situación humanitaria. María José, otra pregunta para ti, que has hablado mucho de la necesidad de integrar los temas de sexualidad en las escuelas en educación y también los materiales y el uso de videos. En el caso, si tomamos el caso, por ejemplo, de un índice de estigma que se ha implementado aquí en Brasil, en el contexto tuyo, y si tomamos, por ejemplo, si los datos de la encuesta Estigma y Discriminación en Brasil muestran que la mayoría de las personas sufren algún tipo de violencia y discriminación a su condición serológica y no buscan ayuda por desconocer sus derechos y los mecanismos, ¿cuáles son los principales instrumentos e instituciones en su país a los que pueden recurrir, si esto fuera el caso en Uruguay?
Bien, en Uruguay el activismo en VIH es bastante reducido, es como que nos conocemos todos, todas y todas las instituciones, y si bien somos pocos y poques, logramos articular la respuesta. Yo trabajo en ACEPO, Asociación de Ayuda del Cero Positivo, que es una asociación que hace bastantes años que está, yo ingresé en el 2006, pero hace como 30 años que está, y en la misma, en convenio con el gobierno municipal, tenemos una línea de teléfono gratis y confidencial, que es el 0800 31 31, asterisco 31 31 de ANSEL, que es una línea que se llamaba línea SIDA, ahora se llama línea VIH, Sexualidad y Derechos, que es una línea a la que cualquier persona puede llamar para preguntar cualquier cosa acerca de lo que el nombre de la línea dice, ¿no? Ya sé, al principio solamente se focalizaba sobre el VIH-Sida y ahora se amplió y también se responde eso y se acompaña IVE y se acompaña todo lo que tiene que ver con otras ITS. Eso es un recurso que cuenta la comunidad, que es utilizado, que estaría bueno que se difundiera más. Ahora le agregamos WhatsApp, le agregamos también en una página web. Un lugar donde articulamos lo que tiene que ver con dar respuesta al VIH es también en la CONACIDA, ¿no? Que es donde participamos como de alguna manera distintos protagonistas, autores, actores que nos interesa esta temática que acá en este país ha desaparecido prácticamente. Por lo tanto, somos pocos, estamos organizados, organizadas, se puede recurrir, pero no es un tema que se hable acá. Entonces, ¿con qué puede contar la comunidad? Con ACEPO, puede contar, hay otra organización que se llama ICW, que todavía está, la red de personas viviendo con VIH-Sida, eso en Montevideo. Después, en lo que es los otros departamentos, hay muy poca organización, y otra cosa significativa es que cada organización no tiene más de 4 personas. Por lo tanto, a nivel de visibilidad, solamente la sociedad civil en este momento está haciendo como un trabajo educativo y para afuera, trabaja en consejería, con grupos de autoayuda, articulamos todo lo que tiene que ver con personas privadas de libertad. Ese teléfono está constantemente recibiendo, no encontré la medicación, el médico no me atendió, y como estamos y conocemos a los doctores, a los que están en el ministerio, tenemos esa posibilidad de levantar un teléfono y gestionar soluciones asertivas para cada situación que se encuentra. Indudablemente que retomando un poquito lo que plantean todos los compañeros del panel, la sociedad civil organizada sigue siendo el motor para intentar que esto vuelva a estar en agenda, y creo que es el más importante recurso que tiene la comunidad para avanzar en esta temática.
Muchas gracias, María José. Brevemente, dos últimas preguntas. Matías, el estigma y la discriminación contra las personas que viven con el VIH se cruzan con otros tipos de prejuicios. ¿Cuál es el impacto de la cuestión de género en el estigma y los prejuicios en su país?
Bien, yo creo que la cuestión de género atraviesa al VIH desde sus inicios, ¿no? Y las dos grandes regiones en donde la epidemia tiene mayor fuerza, tanto en el África como en la región de Latinoamérica, tienen su cuestión de género bien afianzada. A nosotros y nosotras nos toca los fuertes componentes de estigma y discriminación hacia personas trans y varones que tenemos sexo con otros varones, pero también con una fuerte incidencia en nuevas infecciones de mujeres, sobre todo también mujeres jóvenes y mujeres con avanzada edad. En ese sentido, creo que en los últimos años ha habido varios avances en función de políticas contra la violencia de géneros en general, y en relación a la cuestión trans, ¿no? Entendiendo que todavía falta muchísimo. Bueno, las redes de personas trans están trabajando muchísimo por el reconocimiento de la identidad y por el reconocimiento de los derechos sociales. En ese sentido, creo que estamos en un momento bisagra en el cual la sociedad empieza a entender que hay determinados grupos vulnerados que sufren aún mayores niveles de violencia que otros, y nos parece que en ese sentido tenemos que presionar para poder conseguir estas leyes de inclusión, tanto laboral como de vivienda, como sanitaria también y educativa de las poblaciones trans, para poder también un poco equiparar y llegar a la equidad, a la igualdad que tanto se habla desde hace muchísimo tiempo, pero sin embargo hay determinados colectivos que todavía siguen por detrás. Por eso, en ese sentido, pensar que, si bien, como decían las compañeras, la sociedad civil sigue trabajando fuertemente y creemos que en esta situación, en este año, han sido de los grandes protagonistas, también se entiende que todo el peso viene cargado sobre nuestros hombros, y eso genera cansancio, y de esa manera creo que tenemos que pensar como sociedad civil en enganchar a los gobiernos, en convencer a los gobiernos de poder pensar en políticas contra el estigma y la discriminación.
Muchas gracias, Matías. Y si me permiten, la última pregunta aquí para Silvia. En términos de las poblaciones más vulnerables, particularmente nuestra población trans, ¿qué podría hacer en su país para reducir estos prejuicios y el estigma que sufre esta población en particular?
Yo creo que es muy importante decir, ¿verdad? En este sentido, nosotras hemos apoyado al Ministerio de Salud y como también a la respuesta nacional en la Comunidad, es decir, toda nuestra vulnerabilidad y también ponernos a la orden para los procesos de capacitación con los recursos humanos del Ministerio de Salud. Que me vean a mí tal cual, como soy, eso les ayuda a entender cuáles podrían ser mis necesidades, los mecanismos de atención. Y esto es muy importante. No podemos perder la oportunidad de que nuestras voces se sigan oyendo en estos espacios de toma de decisión. Quiero rescatar, y en ese sentido se ha hablado del proceso de investigación, pero también en la región de nuestros países teníamos CONCASIDA, que era el espacio para articular investigaciones en SIDA, el Foro Latinoamericano de VIH, que era para toda la región de Latinoamérica. Estos dos espacios se han caído y en esos espacios eran un bastión importante para colocar nuestras agendas, nuestras necesidades y un espacio de diálogo. Ahora nos queda solamente la Conferencia Mundial de SIDA y esta generalmente se hace en países donde ponen restricciones. Creo que esto nos debe llamar a la conciencia, que es muy importante, que así como construimos con evidencia científica el estigma y la discriminación, lo que atañe, lo que daña, lo que ocasiona en el tema de la salud, también debemos de decir con evidencia científica a nuestros tomadores de decisiones, inviertan para que esta situación cambie, inviertan en población LGBT con todas nuestras diferencias, pero inviertan mejorando el acceso, no solamente el acceso a la salud, sino a la educación, al empleo, a la vivienda, a todos los derechos económicos y sociales.
Muchas gracias, Silvia, por ese importante mensaje. Gracias a todos los panelistas. Aquí ahora le entrego la palabra de regreso a Javier, que nos va a entrar a la sesión de preguntas y respuestas. Gracias a todos.
Gracias a todos y todas y todos los panelistas y por supuesto a Claudia, que ha hecho un excelente trabajo y ha preparado una diversidad de preguntas para que sacar mejor provecho del poco tiempo que teníamos con estos 4 fantásticos líderes y lideresas. Una pregunta que está clarísima y quizás dirigida a Keren o a María José. ¿Qué impacto tiene lo que mencionaba Matías hace un rato sobre la noción de que una persona indetectable no puede transmitir el virus? Tiene para las mujeres que viven con VIH. Podemos empezar por Keren y después por María José, breve, así podemos compartir una pregunta también con Matías y con Silvia. Disculpen que es una pregunta profunda, pero breve. ¿Keren?
Voy a ser lo más breve posible porque cuando pienso en I igual a I, se me viene en Honduras totalmente, es diferente el tema en Argentina y, claro. Y en Honduras el I igual a I todavía no se llega. Y tengo un poco de temor, esto ya es personal, tengo un poco de temor de que mucha gente, o las mujeres con VIH, tomen el I igual a I como que no, ya el VIH no se pasa, eso ya no, ¿para qué? ¿Para qué usar condón? Entonces primero, para mí, tenemos que seguir con la información en países centroamericanos, empezar desde cero otra vez con la información, con el VIH, lo base para poder hablar de igual ahí. Y en términos de mujeres con VIH es un gran avance, porque podemos estar embarazadas, podemos tener parto más natural, podemos tener hijos sin riesgo al VIH, eso en términos de mujeres y en Honduras.
Muy bien, y creo que está señalando que no es una fórmula mágica, que hay que asegurar el acceso continuado e ininterrumpido al tratamiento, a las pruebas de carga viral, y que América Latina son muchos países de una misma región y donde la inequidad es un tema. María José, la misma pregunta.
Bien, en primer lugar, obviamente que es muy importante la intersección, ¿no? del nivel educativo y de los recursos económicos para hablar de indetectables igual intransmisible, ¿no? No solamente que lo sepamos, sino que en la vida cotidiana se pueda llevar adelante. En lo que refiere para mí, en relación al género y en relación a ser mujer, ya de por sí se nos ha negado de arranque históricamente la sexualidad, el placer, el goce, nombrar nuestra genitalidad, ser libres, poder disfrutar, y eso ya históricamente a la mujer que de alguna manera vivía eso ya ha sido catalogada como puta, como loca, como desviada, ¿no? De alguna manera el VIH viene a reconfirmar el discurso, los discursos que hay alrededor del VIH vienen a reconfirmar un poco en el imaginario, ¿no? En la construcción del imaginario, eso, ¿no? Como que devolución del diagnóstico de alguna manera te reconfirma esa idea loca, ¿no? El vivir nuestra sexualidad plena, que es un derecho sexual, reproductivo, por lo tanto humano, se ve restringido muchas veces por la idea que nos hacemos de nosotras mismas por tener un diagnóstico positivo. Eso influencia en la vivencia de la sexualidad, porque no sé si decirlo, lo digo y capaz que no. Entonces, el hecho de tener el dato de que tenés la tranquilidad de que pese que igual uses las barreras de protección, ¿no? Que a veces igual usando una tiene como la fantasía porque se siente como una bomba contaminante, porque es lo que nos han enseñado, creo que nos libera muchísimo, nuevamente, el feminismo nos viene liberando históricamente de lo que tiene que ver con no gozar nuestra sexualidad, y pienso que esta información de alguna manera nos vuelve a liberar de esa cárcel en que el diagnóstico nos podría llegar a poner o nos pone a muchas mujeres al vivir nuestra sexualidad plenamente.
Muchísimas gracias. Matías, vos que trabajás en una asociación que se ha embanderado muchísimo con el tema de Igualaí, ¿qué efectos beneficiosos, aparte de los que mencionaba María José y Keren en un contexto de buen acceso, tiene esta buena noticia que hay que comunicar a los cuatro vientos?
Yo creo que el efecto más inmediato, me parece que la población esté informada siempre es positivo, ¿no? Porque la información es la herramienta que nos permite tomar las decisiones con libertad. Si yo estoy informado, si yo sé de algo, estoy parado en un mejor lugar para tomar alguna decisión de lo que sea. Específicamente con respecto de Igualaí, tiene que ver con las relaciones sexuales, con el disfrute, con pensar cómo relacionarme con un otro. Pero me parece que uno de los efectos que vemos, además de tener mayor y mejor información, es el de reducir el rechazo, ¿no? Y lo pienso porque lo pienso desde el punto de vista de Igualaí en relación a la transmisión sexual, específicamente como dice el postulado del Partner 2. Y me parece que eso se ve menos rechazo, ¿no? Lo vamos viendo en los diferentes grupos de personas con VIH que todavía seguimos manteniendo. La información va llegando, de a poco va llegando y eso se ve en menos rechazo de relaciones sexoafectivas. Y no solamente lo digo como varón que tiene sexo con otros varones, sino también en relaciones heterosexuales, en otro tipo de relaciones también. Me parece que parte una de los resultados es en el menor rechazo, la menor discriminación en relación a poder conseguir una pareja sexual, una pareja amorosa, y eso lo vemos. Creo que eso es una victoria del activismo, porque realmente esto es una puja del activismo. Ahora de a poquito se va sumando los equipos de salud a difundir el mensaje también, pero bueno, será también tarea nuestra hacer que la información llegue a más personas.
Exacto. Y también poner el énfasis, como bien decías, el estudio Partner 2 habla sobre relaciones sexuales. Hay sobradas evidencias que la misma ecuación de I igual I funciona para la gestación, para el parto, para el amamantamiento. O sea, cambia totalmente el paradigma de casi te diría la violencia institucional que se ejercía sobre las mujeres y sus parejas viviendo con VIH en el sistema de salud, ¿no? Uno de los lugares donde la mayoría de las poblaciones claves han identificado donde sucede más el estigma y la discriminación. Y también un poco ustedes han estado hablando de algo que por ahí no se mencionó por el nombre, pero es el autoestigma, ¿no? Un poco lo decía María José, un poco lo dijiste vos, Matías, un poco Keren. Pero nos queda muy poco tiempo y quería hablar con Silvia un poquito la bajada a realidad, a una realidad que no nos tiene que pinchar las buenas noticias, pero es la realidad de vivir en un contexto de emergencia. Entonces quería la última reflexión de Silvia, por cómo ha pasado en Venezuela, cómo ha pasado en Centroamérica, antes y durante y después de la tragedia climática y con el coronavirus en muchas partes de la región. ¿Qué es lo que pasa? ¿Cómo hace una persona trans para acceder a un servicio de salud durante una cuarentena, durante una respuesta de emergencia humanitaria, militarizada, etcétera? Silvia, algo que nos puedas compartir, porque también lo vemos con el COVID.
Sí, en este sentido creo, Javier, que es importante colocar dos cosas. Una persona trans en una situación de emergencia no existe, no cuenta, ni siquiera tiene servicios. Eso es muy importante decirlo. Generalmente las líneas prioritarias son todo el mundo, menos las poblaciones en mayor riesgo. Dos, además de que los países enfrentan diferentes situaciones, tenemos, ejemplo, el tema de estos dos huracanes que acaban de pasar, han dejado parado cierto transporte de medicamentos que vienen a ser entregados y dispensariados en los diferentes puestos médicos, etc. También el tema del burning up, el quemado, como lo han dicho de alguna manera. Los recursos humanos están pasando crisis con el COVID. Ahora además le agregas el tema de estas emergencias o las cuarentenas. Hubo un momento, en Nicaragua no hubo cuarentena, pero sí mirábamos, por ejemplo, que en otros países la crisis emocional que se vivía, pero también el no vivir en una cuarentena puede haber sido un reservorio para el COVID-19 y ahora esto nos coloca en mayor riesgo por el tema de esta emergencia climática. Creo que es muy importante hacer esta reflexión, ¿verdad? Sobre todo porque en la mayor cantidad de prestación de servicio público o privado, las personas de la diversidad y sobre todo las personas trans ni siquiera existimos como prioridad. Entonces, desde ahí se cae el nicho o el mensaje de que el acceso universal para la salud es realidad. Entonces, ahí yo creo que es importante decir que es una materia pendiente y sobre todo cuando en los países sucede una o X situación que cambia el entorno y de alguna manera esto nos coloca
Totalmente.
Que al pasar en un estado de vigilancia o de supresión de policía, mis derechos no son derechos, pasan a ser cualquier otra cosa menos derechos humanos.
Muchísimas gracias, Silvia. Bueno, nos hemos quedado sin tiempo y lo que dice Silvia aplica para toda la región y para todo el mundo con el COVID. Gracias, Matías Muñoz, gracias, Silvia Martínez, gracias, María José Hernández, gracias, Karen Danaway y, por supuesto, a mi coequiper Claudia Velázquez por esta mesa sobre estigma y discriminación, donde hemos tocado otros tantos temas importantes. Le paso entonces la antorcha al presidente de la Sociedad Argentina de Infectología, casi digo de SIDA, el doctor Omar Sueldo. Muchas gracias.
Perdón, gracias, muchísimas gracias a todos. Parece que no estaba hablando, parece que estaba sin micrófono. Para mí ha sido un placer verlos, escucharlos. A Matías, un amigo, a Keren, que no la conocía de antes y ha sido un placer. A la compañera de Uruguay también. Y Silvia, es un gusto escuchar tu relato tan concreto, tan así, real, digamos, ¿no? Y entonces es buenísimo felicitarlos a ustedes por este activismo y tratar de invitarlos a que seamos clientes frecuentes de estos espacios con la Sociedad Argentina de Infectología, que desde ya tiene las puertas abiertas para estas interacciones con Javier, que también es un amigo de la casa, con el apoyo de la IAS, porque, digamos, es parte de la responsabilidad de la IAS. Entonces, doy paso ya a la reunión de cierre. Primero que nada, agradecer a todos ustedes. El segundo tema es que quiero darles, a ver que pase esta diapositiva, exacto, acá, quiero dar las gracias a todos los participantes, esperemos que haya sido interesante. Queremos agradecer a Merck, a Chardom, a VIV, a la Agencia Suiza para el Desarrollo de la Cooperación. Queremos invitarlos a todos los que están escuchando que se hagan socios de la Sociedad Internacional de SIDA, obviamente que de la SADI también. Hay una oferta que está en pantalla para todos los miembros jóvenes y estudiantes para tener una suscripción en la IAS de 6 meses gratuita. Y el objetivo de esta reunión, bueno, era reducir esta brecha justamente que existe entre el nivel de conocimiento que tenemos y el impacto de salud pública por la falta de implementación de algunas de estas medidas que ya sabemos que son de eficacia comprobada. Como ustedes bien mencionaban, el solo hecho de poder decirle claramente a la gente: estás en tratamiento, estás indetectable, no transmitís, quédate tranquilo, tiene un impacto inmenso en la vida de las personas y los médicos tienen que aprender a decirlo así de claro. Esperamos que les haya sido de utilidad, esperamos que no sea la última. Les pedimos que recuerden que van a recibir una encuesta por mail, por favor complétenla porque es la única forma de saber si las cosas que estamos haciendo las hacemos bien. Gracias a todos, cuídense y esperemos que no sea la última vez que estemos compartiendo una pantalla y que en muy poco tiempo podamos compartir una mesa más cerca. Muchísimas gracias a todos, un placer. Dejamos entonces la mesa para el doctor Cohen, que se va a unir en pocos minutos. Muchísimas gracias, completen la encuesta. Adiós.